I'm Melissa Barnett, and I'm very pleased to present the iDetect KC program. The indications for cross-linking are listed below. A disclaimer is that this information is not treatment advice for any particular patient, and please reference the full prescribing information if you would like more information. I'm very pleased to speak on behalf of Glaukos for this presentation. What is keratoconus? So keratoconus in my practice is a highly prevalent condition. I can see 12 patients in a morning that have keratoconus. And the really good news is that there's increased awareness. I think Steph Curry, unfortunately, I personally don't see him, although he's just an hour away from me, has had issues with his eyes and was diagnosed with keratoconus, and now is playing even better than before because of his corrective scleral lenses. It was previously estimated that 1 in 2,000 patients had keratoconus. A study in the Netherlands in 2017 states that it's 1 in 375. A study that came out last year from Australia stated 1 in 84. All of these studies tell us that keratoconus is probably much more prevalent than we think. And I'm going to share with you today some new information that's going to help you in your practices to help diagnose keratoconus earlier rather than later. A study here you can see on the left-hand side from the Survey of Ophthalmology in 1998, note the date there, stated that 1 out of 5 patients with keratoconus will need a corneal transplant. Fortunately, because of early diagnosis, detection, and management, we can change that number so not as many patients need a corneal transplant. And there have been some recent studies that demonstrate this. But the key here is that we want to detect patients earlier rather than later. Keratoconus can be difficult to diagnose without advanced diagnostic tools, especially in the early stages. So if a patient comes in and they report a history of like eye rubbing, and that's not just the gentle rubbing, of course, that's the deep eye rubbing. They come in with blurry vision or changes in vision, any loss of best corrected vision. So if a patient is not 20/20, I'm thinking keratoconus. Is it keratoconus? Is it something else? Patients can also say that they're having difficulty with eye strain. Their eyes are red, irritated, they're sensitive to light. It can really affect their day-to-day quality of life. Now, I work in multiple practices. 2 of my practices have all the toys and bells and whistles, and I can image the front and back of the cornea easily. One practice with a student population on campus, I don't have any of the fun toys at all. And so what I use is my auto keratometer and my keratometer to pick up keratoconus. And this is a really helpful tool. So looking at the Myers, if the Myers are distorted, we can find a lot of astigmatism. If the Myers are changing with the blink, it makes a difference as well. And so that's something that I use in my day-to-day practice. Another thing that I find is really helpful is retinoscopy. And I teach this to residents as well. But pull out your retinoscope and look for scissors on retinoscopy. That's a really good way to pick up keratoconus if you don't have the fun tools. Increase in myopia or changes in astigmatism, changes in the amount or axis or rotation of astigmatism. Of course, looking at keratometry values are all important when we're looking for keratoconus. Of course, additional things like striae, scarring, these are all things that we're looking for in order to diagnose keratoconus. But really, topography is the key to diagnosing keratoconus. It's much more accurate than all of the things I just mentioned because it can be used to detect increasing astigmatism. It can be used, of course, to check the corneal curvature and determine the maximum corneal curvature in different meridians on the cornea. And here you can see just some examples of keratoconus. I'll draw your attention to the bottom middle one here, the nipple cone, and then the oval cone to the right, and then the globus cone. And of course, we do pick up a lot of for us keratoconus in our practices as well. And this is important when we're counseling our patients about refractive surgery. Perhaps they're not the best candidate, and could a procedure like iLink be done to prevent progression? That could be an option as well. So I think I mentioned how important it is to diagnose patients early. The earlier, the better. And those of us, we all know how difficult it is to fit the most advanced patient with keratoconus with a really steep cornea, scarring in any sort of specialty contact lens, and how much easier it is to fit a patient who, say, has been cross-linked and is much more mild. We have many more options when we're talking contact lenses for those patients. We know that progressive keratoconus can lead to a loss of visual acuity, and many of my patients, they want to wear glasses even just around the house just to get by. And many times with advanced keratoconus, there's really no way that they can do that because of the high level of irregular astigmatism. In advanced cases, contact lens fitting and wear is really challenging. And the earlier that keratoconus is diagnosed, the better, because then we can treat and manage these patients and halt or slow the progression of keratoconus. And one thing that it is, of course, important to discuss with our patients and educate them is that cross-linking is not a refractive procedure. It's not a refractive surgery, but it's something that really helps them throughout the rest of their lives. We want to diagnose and manage our patients before there's any loss of visual function. So just a brief review of FDA-approved cross-linking. The products include Photrexa Viscous and Photrexa and the KXL, or the UV light, and this is the same procedure that has been around. So it was originally introduced by Avedro and is now marketed as iLink. The mechanism of action, of course, we know for corneal collagen cross-linking, combines the UV light and riboflavin or vitamin B2 drops, and the absorption of UVA by riboflavin generates a radical riboflavin and singlet oxygen to form crosslinks. So it makes the cornea stiffer and stronger, and thus prevents the cornea from progressing. And corneal cross-linking really helps create the new collagen crosslinks, and it leads to stiffening of the cornea. So the iDetect KC program, this is really an exciting program. So this is a joint relationship with Glaukos and Topcon. And what this program does is it offers a new topographer at a really amazing price, a price that you cannot find anywhere else. So the price is $8,990 compared to a list price that is much higher. This gives the opportunity for a 2-year warranty. It is a simple system, and it has financing available as well. Now, of course, today we're talking about keratoconus, which is really exciting. So having this instrumentation, you'll be able to diagnose keratoconus and manage it much earlier. On the Topcon system, there is the KPI. Here you can see at the bottom right, which shows the percentage probability that the eye is keratoconic. And I'll be showing you a few examples in a moment. The symmetrical symmetry of superior and inferior shows the asymmetry of the curvature between the locations in the superior and inferior cornea. So here are some examples of a patient who has keratoconus. And if you look at the KPI for this patient, quite obvious, you can see the inferior steepening, both eyes, and the KPI is 100% for each eye. Of course, you can bill and code for this topographer, and not only just for the topographer and keratoconus, but other conditions as well. Say Salzmann's nodular degeneration with irregular astigmatism, What about corneal edema, corneal scarring, any sort of corneal irregularity? And here you can see the codes that are used and also the reimbursement amount on the right. For managing keratoconus with cross-linking, it differs as far as the individual follow-up, might depend on the surgeon that you're working with, but all of these visits are billed independently, so they are not in a global period, which is really nice. And of course, all sorts of imaging like topography, OCT, etc., can be billed as well. We can't forget specialty contact lenses, which of course it's important to charge for the fitting and materials of specialty contact lenses as well. The really neat thing about this topographer though, it has additional functions such as tear breakup time, evaluating the meibomian glands, which I think is fascinating because we all don't have meibographers in our practice. We can check things like tear meniscus height. It can even be used for contact lens fitting, including ortho-K, corneal GPs, and of course can be used to co-manage refractive surgery as well. A nice, really interesting project that is associated with this is a data registry that is not required, it's optional, but I think it is something that will give us as doctors a lot more information moving forward. So this data registry, the goal of it is to compile a large data set confirming the efficacy of Glaukos's iLink collagen cross-linking procedure for treating progressive keratoconus. Things included in this registry will be steep K, flat K, the KPI, and SI, the values I went over previously. And this data will be really helpful to look at keratoconus moving forward and the importance of diagnosing and treating prior to our patient's progression. And this will really help, most importantly, our patients. And again, not only our patients, but their families. It'll help our patients thrive. So this registry can be used for all suspects. Perhaps you have a patient who has an increase in astigmatism or some asymmetry. You can evaluate them as well. 95% of patients with keratoconus have K values greater than 45. So even right now, if you're checking for keratometry, manual or automated, look for that value and be suspicious of keratoconus if they're over 45 diopters. We want to look at astigmatism and if astigmatism is greater than 2 diopters, especially how the astigmatism looks, is it regular or irregular? Patients can be a suspect as well. Looking at the Kmax difference of more than 2 diopters is something to evaluate, and of course the inability to autorefract. So the iDetect KC data registry using the TopCon instrument can really help us diagnose patients earlier, manage them earlier, which is most importantly going to help our patients. I do want to thank you for your time and attention. If you have any questions, please email the idetectkc@glaukos.com. And here at GSLS, please visit the Glaukos booth for additional questions. Thank you.